So guys, this is the continuation of our lecture that was on interceptive orthodontics. Actually, I want to repeat one of the slide over here again because I feel that I could not explain it in my earlier lecture. We were talking about one of the removable appliance that is called Hollis appliance with a slingshot elastic that was used as a distalizer. So I want to explain here because I could not find the exact picture. You just feel this is the empty space and here is nothing present. Okay. In this type of appliance, what do we do is quickly at the mid of the molar, which needs to be distalized, we add a hook on a plate on the lingual side, as well as we give another hook over the Adam's clasp on the buccal side. You see, this is the buccal side of a tooth. This side is called as buccal side for B, and this is called as lingual side. On lingual, we have a acrylic plate, so we added a hook over the acrylic plate. But on the buccal side, we do not have acrylic plate. We have an Adam's clasp. You see, the design of the Adam's clasp is somehow like this. These arms we see over here of the Adam's clasp, and this arrowhead is present on the buccal side. So on the buccal side, between these two hooks, these two arrowheads, we add a hook like this. So this elastic, I'm talking about this elastic is actually applied on two sides. One on the palatal side or a lingual side, depending upon the type of a tooth which we are going to distalize. If it is an upper arch, then we give the palatal side. If it is a lingual arch, then we will call that we are giving the hook on the lingual side of the plate. After giving a hook over here and after giving a hook on the buccal side, we used elastic on both sides. One elastic on the palatal side, which will be attached to another hook on the premolar. And this is the empty space where we need our tooth. Actually, this is the empty space which is occupied by drifting of this tooth. We need this tooth to be back to its position. We need this to be distalized. So the elastic which is present over here on the lingual side, what will it do? You see the force of elastic will be in such a way, it will direct the tooth this way on the palatal side. The palatal side means this portion of a tooth will be going this way, and the elastic which is present on the buccal side will be joined with this tooth. So that will force the tooth to go in this direction, in the distal direction. This way, the tooth, the whole length of the tooth will be moved, and somehow the tooth will be in this position. You see, earlier it is tilted over here. So it will be back to its original position. This portion of the tooth will be present, means move little distally, and this portion will move little mesially. This way, the tooth will have its proper position in the arch, which was before like this a little. It was tilted a little. I'll make it over here, which was somehow like this before. So this is actually the action of the elastic to make the tooth in the proper position into the arch. So rest of the things I explained over here. Now we are going to start with correction of the crossbite. Actually, other topics of the removable appliances I cleared over here with the distalizers. So we'll be talking about the crossbite now. What is the crossbite? What is the anterior crossbite? What is the posterior crossbite? I gave some idea of the crossbite in the last lecture as well, but I want to continue with the crossbite again in a proper way. So we shall have a good explanation of the crossbite here. So what is the crossbite? As I told you, crossbite is a correction of relation of the teeth. First of all, we should understand the normal relation of the teeth. The normal relation of upper and lower teeth is this way. The upper teeth and these are the lower teeth. We are talking about the incisors. This is the normal class 1 incisor relationship. But if the relationship is not so, the relation is somehow changed like this. The central incisor is somehow like this. The normal relation is this. But if the central incisor is somehow like this, instead of being ahead of the lower incisor, it is actually blocked. It is actually blocked here by lower incisor. Then we don't call it a normal class 1. We rather call it a crossbite. Similarly, we have a crossbite in the posterior region. We'll be discussing it and we will understand how to treat it. I hope I'm clear. This picture is showing you that these teeth, these central incisors and these lower central incisors are in a proper incisor relationship, if we see here. But if you see other central incisors like this and like this lower central incisor and the lower central incisors of the other side, these are not in the normal relationship. They are in the crossbite. Instead of upper teeth overlapping the lower teeth are overlapping the upper teeth. So the crossbite need to be treated if it is present in any segment. If it is present into the anterior segment, we call it an anterior crossbite. If it's posterior segment, we call it a posterior crossbite. During the mixed dentition period, it is needed to be corrected as early as possible. Because during the mixed dentition period, we know some of the teeth are deciduous in the arch and some of the teeth are permanent in the arch. So we need to begin our treatment as early as possible. The crossbite can be unilateral, present on one side. It can be bilateral, present on the both sides. It can be true or it can be functional. True means a well-established crossbite. Functional means because of the abnormal posture of the jaw, there is a crossbite that is called as functional crossbite. If it is not treated at a specific time, then it may lead to skeletal malocclusion. And these skeletal, see from dental, the malocclusion is switching to the skeletal. So these crossbites are to be treated as early as possible during the mixed dentition period in order to prevent them to cause skeletal malocclusion. Because once there is a skeletal malocclusion, then this malocclusion cannot be treated with the simple interceptive orthodontics. It requires corrective treatment that is called as corrective orthodontics. So what are the ways to treat the crossbite? It depends upon in which region it is present. It depends upon how many teeth are included, and it depends upon age of a patient. Number one, the appliance we use is a tongue blade therapy we give to the patient. This is actually a picture that shows a stick is placed into some part of the stick is present between the upper and lower central incisors, and the rest of the rest part of the stick is projecting outward, and we ask the patient to hold this stick and do the exercise. As you see here, let me make it clear. If you focus on this tooth is little inward, more palatal. So as the child will be applying pressure, the outward pressure on this stick, the part of the stick that is in contact with, on the palatal surface of this incisor will pull the tooth outward. So this stick that is called as tongue blade therapy, that will give direction, the movement of the direction of the stick is outward, so it will guide the tooth to be pulled outward. Okay. So what at the same time, what this stick is doing, because early I told you this tooth is somehow like this. I'll make the picture. This tooth is somehow like this in a crossbite, where the lower central incisor is overlapping this central incisor. This central incisor is overlapped by the lower incisor. So what this tongue blade will do, when we place this tongue blade in between these teeth, I'll make a diagram. This tongue blade, as soon as we place this tongue blade, there will be, you see here, this is the tongue blade. The part of the tongue blade is also present over the palatal side. This is the palatal side. This piece of the tongue blade is touching the palatal surface of the tooth, and rest of the tongue blade is present outside. And this is the lower incisor present over here. Sorry, my drawing is not that good, but I'm trying to explain it. So earlier the relation was like this. As soon as we give the tongue blade, what this tongue blade do, it creates a space between these two teeth. The tooth which was locked, the upper tooth which was locked by the lower tooth, is no more locked by the lower tooth because the tongue blade is present in between. Okay, so the tongue blade, one way it has opened the bite. Number two, as soon as the patient tries to pull this tongue blade outward, it will apply the similar pressure on this tooth, which is locked by the lower incisor, and it will be moved outward. And the presence of the tongue blade has actually kept the lower tooth away to contact the tooth which need to be out. So this way, there is a space present that allows this tooth to be pulled outward. In this case, you cannot take this tooth outward because this is locked by the lower incisor over here. So to disocclude these teeth, you need to have some instrument in between, or some sort of therapy, some sort of, you can say, or you can call it an instrument present in between that should allow the bite between the teeth to be open, and as well as guide the tooth to be positioned or to be pulled outward. This is number one. Number two, then we can give inclined bite planes. These are called as bite planes. We make a removable appliance, and in which we incorporate the bite plane and we give to the patient. We can have composite inclines. We can have quad helix. We can have Hawley's appliance with Z-spring. We'll be talking about all of them separately. I'm not talking about all these over here. I'll be talking about all of them in a different, in another lecture series of mine. And right now I have just given some idea to you that how do we do interceptive orthodontics and what does it include. So one of the treatment we do in the interceptive orthodontics is also a crossbite. Then elimination of the abnormal habits. At the beginning of the lecture, I told you that if we do not eliminate the habit, then there is no use of giving treatment to a patient. Because if the etiological factor will persist, there is no use of wasting time, and there is no use of treatment because the treatment will not produce any effect. So you see these examples I have brought over here to explain to you that there are some habits you are studying, so you know what are those habits that can produce orthodontic problem. It could be a tongue thrusting habit. You see here, patient is having habit of keeping the tongue in between the upper and the lower teeth. This is called as tongue thrusting habit. This tongue thrusting can also be in this region. Some patients have habit of keeping the tongue laterally. So that is called this lateral tongue thrust habit. So the tongue thrusting, the patient is thrusting the tongue between the teeth. It could be in the anterior region or it could be in the posterior region. So what this tongue thrusting will do, it will cause not only the dental problem, but it will cause the skeletal problems also. Some patients have habit of lip sucking. Again, the pressure exerted by the lip muscle will cause a lot of dental issues. Some patients, due to stenosis of the nose, adenoids, can have breathing from the mouth because the nasal cavity is blocked. So they cannot use the nasal cavity properly to breathe. So these are called as mouth breathers. They breathe from the mouth. Another habit is called as thumb sucking habit or digit sucking habit. That is normally we see in the children that to just pacify their need, or when they are in the anger or when they want to sleep, they start sucking their digits. It could be fingers, it could be thumb. So these all habits ultimately, if not treated or if not discouraged early, may cause a lot of problems, the dental problems. Usually we see that they all cause the problems. Amongst them, the most common cause is class 2 malocclusion. I hope you guys know what is class 1, what is class 2, what is class 3. So that cause, these habits mostly cause class 2 malocclusion. We'll be discussing about all the malocclusions with their treatment in detail. But right now I shall make you understand what is class 2 malocclusion. Class 2 malocclusion is the one when your patient is having prognathic maxilla and retrognathic mandible. You just see this is the nose. I hope my drawing would give you a good idea. I'm trying my best to explain. Sorry, I'm not that, it's not easy for me to draw with this, but I'm trying to make it possible. You just see, this is the patient, this is the maxilla, and this is the mandible. The maxilla is protruded outward and mandible is retruded. So when the maxilla is protruded or maxillary teeth are proclined and mandible is retrognathic or mandibular teeth are retroclined, then we call it a class 2 malocclusion. It could be of a skeletal type if the bone is involved, or it could be a dental type malocclusion if the only dentition is involved. So this is actually the case of class 2 malocclusion. You see here, actually, if you see the profile of this patient, if I draw a profile, this patient is having a convex profile. So the convex profile of this patient is actually giving appearance of class 2 malocclusion. Why this patient is having convex profile? Because the patient is having recessed chin, the recession of the chin. Why the chin is recessed? It can be due to several reasons. It can be because the patient is mouth breather, the patient is having nasal stenosis, so patient is unable to breathe from the nose, so he is having habit of breathing from the mouth. So that can lead to recession of the chin and gives this appearance to the patient. So these etiological factors can cause class 2 malocclusion, that class 2 of an imbalance of the musculature. As I told you, the child is having habit of lip sucking, tongue thrusting, and mouth breathing because the oral cavity, this dentition is surrounded by the muscles of the tongue from inside and muscles of the cheeks and lips from outside. So this musculature, the blanket of the musculature from both sides of the teeth plays a very important role in the dentition to keep it normal or to give abnormal appearance to them. If there is any abnormal activity of the musculature present, then that musculature exert abnormal forces on the dentition and it causes malocclusion. Not only the dental problem, but that problem, the abnormal muscular forces, if not treated early, they may cause the skeletal malocclusion. As I told you, not only the muscles of the cheek and lip, but the muscles of the tongue does play a role in the positioning of the teeth and jaws as well. You see here another example. Can you see here the arch? If we see this arch of the patient is very narrow. Why this arch is narrow? Again, the patient may have the habit of digit sucking. The child is continuously keeping the thumb over here to suck. When the child keeps the thumb inside the mouth, what happens? The force is exerted by the muscles. I'll show you the picture here. You see, if this child is continuously doing the thumb sucking, the thumb is present inside, which was present touching the palate. To hold the thumb, to make a good suction, the child exerts the pressure over the thumb, because for sucking the thumb, he will apply pressure from the all of the muscles of the lips and cheeks to create a pressure inside to make him a good feel. So for the pressure, the child apply forces over the musculature, and those forces not present only on the thumb, but at the same time, these extra forces which are generated, they are at the same time applied over the bone as well as over the teeth. Like this example, we say these are the dentition. I'm just giving the example of the upper and the lower teeth. This is the dentition. The forces applied from these muscles, the muscles of the cheek, the muscles of the lip, they actually apply the forces on all the teeth which are present inside, as well as on the bone. So what happens? Due to these extra forces, the jaw become constructed, as in this picture. The jaw become constructed because the forces are exerted from these both sides, and as well as the dentition become crowded. You see here, the constructed jaw. Due to constructed jaw, the teeth are not accommodated properly into the jaw. Some of the teeth are going buccally, some of the teeth are going more palatally, and that caused the malocclusion. Also in the anterior region, you see here, this tooth did not accommodate properly, so it is maloccluted. The jaw is constructed at the same time, and patient will have a lot of issues, the dental as well as skeletal issues. So to relieve those forces exerted by these muscles, we need to guide the muscles in a proper direction. How we guide the muscles? We guide the muscles we try to alleviate the forces, or we try to relieve the forces exerted by these muscles over the dentition as well as on the jaw by guiding some exercises to the patient. These exercises will help to guide the teeth to develop in a proper direction, because these exercises will not exert the excessive forces which were applied over the dentition and as well as over the jaws before. So these exercises will try to make these forces away from the dentition as well as from the bone in order to guide the teeth to develop properly. It also allows proper growth because the child is in mixed dentition. As I told you, we begin interceptive orthodontics during the mixed dentition. That means the child is growing. So these exercises also help the growth pattern to the child, and this treatment provide good stability and retention at the end of the treatment. So what are the ways we guide the patient? What are the muscle exercises? It depends which muscle is hyperactive. We guide the exercises accordingly. If the tongue muscles are abnormal or the tongue muscles are exerting pressure, then we guide the patient the exercises for the muscles of the tongue. If it is due to masseter muscle, we give another exercise accordingly. If it is due to pterygoid muscle, we guide the patient accordingly. And if it is due to the muscles of the lip or orbicularis oris, so we guide the patient accordingly. The exercises, how to keep the posture of the tongue, how to keep the cheeks away from the dentition. So there are the exercises which we guide the patient are, for example, if the patient is having hypotonic muscle, hypotonic lip muscle, the lip muscle is hypotonic, the lower lip muscle. So we guide the patient that the patient should stretch the upper lip inferiorly down, inferiorly, and overlap it with the lower lip. This way, the patient will try to begin a lip seal because this patient had no lip seal, his lips were apart. So we are guiding the patient to do this exercise to have a good lip seal. Also, we can ask the patient to keep a piece of a paper over the lips, over the lower lip, and try to hold the paper by stretching the upper lip downward. This is the exercise we give to the patient when there is no lip seal. We can guide the patient this exercise that is called a switching of water. So it guides the patient to, when patient tries to, force swishing the water, that forces that is exerted by the water keep the cheeks away from the dentition. Also, we guide the patient to play the instrument, or there are some, there are some, the appliances we use to guide the proper musculature. These are called as oral screens we use. And how do we use the oral screen? Oral screens are used by means of, we ask the patient to keep this oral screen inside. You see, this is called as oral screen, and we usually give these oral screens to the patient who are actually mouth breathers. So because of the mouth breathing, patient keeps the mouth up, both the jaws apart. Keeping the jaws apart will exert inward pressure on both of the dentition. And this is the reason the patient may have a deep bite and several other issues with the dentition as well as with the jaw. So this oral screen, when patient keeps in the mouth, you see here, these are the upper teeth, these are the lower teeth. And the oral screen is present between the teeth and the lips. So keeping the forces of the lips away from the dentition. This piece of the oral screen is this one, which patient needs to put inside, and that keeps the muscles of the oral cavity, lips and cheeks away from the dentition in order to allow them proper positioning. There is another exercise we call as a button pull exercise, tug of war exercise, but these all depends upon in which condition you are giving and which muscle need to be treated. So this is the button pull exercise. We give this button pull exercise by giving a button. We thread the button with this rope. The button is placed inside the lips. Patient is asked to make a seal, and patient is asked to hold the end of a string and try to pull it outside. This way, the seal of the lip is produced, and as well as the forces exerted by the lips will be relieved. This is called tug of war exercise. It is same like the button pull exercise. Only the difference is there are two buttons used. One button is present inside the oral cavity, and one button is present at the end of the string, on the other end of the string. And the patient is asked again the similar way to do exercise and practice on it to relieve the pressure exerted by the lip muscles. This is for the lips. If the problem is with the tongue, then we guide the patient exercises for the tongue. So how I guide the patient, because the patient during normal swallowing, the posture of the tongue is like you try to swallow, you will feel that your tongue is elevated upward and the tip of the tongue is touching the rugose. But if there is abnormal swallowing pattern, then the patient may keep the tongue in between the teeth and tries to swallow. And this abnormal swallowing pattern can cause a lot of issues with the dentition. So what is the purpose of giving this exercise? We guide the tongue. We want to guide the tongue muscles to have a proper position. So 1 elastic and 2 elastic exercise is given to such patient. We place an elastic at nearly a tip of a tongue. We ask the patient to elevate the tongue and touch the rugose along with this elastic. This elastic will serve as a guide for the patient that this piece of a tongue is supposed to touch the rugose areas. And we ask the patient to swallow. Why are we doing this? Because we want the patient that during swallowing, he or she shall rest the tip of the tongue at the rugose region. There is another exercise for the tongue that is called as 2 elastic swallow. Similarly, we place 1 elastic at the nearly a tip of a tongue and another at the middle on the dorsal surface of a tongue, and we ask the patient to elevate the tongue, again touch the palate and swallow. So when the patient keeps on practicing these exercises, patient will learn that during swallowing, where is he or she supposed to posture his tongue. You see here, after the elastic, we have asked the patient to elevate it. The tongue is elevated, and now we ask the patient to swallow. This way the patient will learn. This swallowing pattern will not only guide the proper swallowing pattern, but you see at the same time, it will help the lower jaw to have a proper position. It gradually guides your mandible to have a proper position, because the tongue muscles, you see here, this is the mandible, this is the tongue. The muscles of the tongue are actually inserted all around into the mandible. So these muscles, they are inserted with the mandible as soon as patient elevates the tongue, as soon as patient tries to, rise the tongue. This, since because of the muscles are attached with the mandible, if the patient tries to elevate the tongue, don't you think that the mandible at the same time is guided forward and upward? So this is way we treat the mandibular posture as well, which was recessed before, which was positioned backward. So we guide the mandible at the same time with the tongue stretch exercise. This is the exercise that is for the masseter muscle. So we ask the patient to clench for 10 minutes, start counting 10 in mind, relax. Again, repeat, again count 10 in mind, and again relax. So this way, the muscles or masseter muscle will have some activity on it, and the excessive forces exerted by it will be relieved. This is the exercise for the pterygoid muscle. You see here the patient, before the patient had the jaw, the lower jaw positioned a little backward. We guide the patient to protrude, to stretch the mandible forward and then relax. Then again, we ask the patient to protrude mandible forward ahead of the lower upper teeth, and then again, when the muscles get tired or patient get tired, then patient should relax. This way, the continuous activity of these muscles or continuous posturing of this jaw in the forward direction will have a stretch on the pterygoid muscle, and then these pterygoid muscles will guide the mandible a forward position, or will guide a mandible a correct position. What are the limitations of these exercises? First of all, before beginning any treatment, we shall know that if the patient is cooperative, then we can carry on the treatment. But if the patient is not cooperative, the compliance of patient is not good, it means there is no use of treatment. Your patient's cooperation, your patient's understanding is very important that what you are going to do. Because if the patient will not cooperate, patient will not participate, you cannot bring out any results for your treatment. Number two, exercises of all the muscles do not drastically alter the bone growth pattern. It is not known that these exercises will produce the effects which we really want, because the literature did not prove it yet. And these exercises are not substitute for the corrective orthodontic treatment. You need to have corrective orthodontic treatment, because we cannot say that the patient is doing exercise and so we do not need any corrective orthodontic treatment. No, this is the limitation of muscle exercise. And if these exercises are not guided properly, then instead of having positive results, you may have altered results or negative results. So we should understand what we are doing and how are we doing. Another treatment which we give in the interceptive orthodontics is removal of the soft and hard tissue barriers from the dentition. You see here, central incisor is present, but this central incisor is not erupted. It is covered by this thick soft tissue, or that could be a bony covering over it. So we need to remove these hard and soft tissue barriers like this, and we allow the tooth to erupt into the oral cavity. So that has to be done carefully and at a particular time. Why are these retained? Why these barriers are present? There are several reasons that the barriers could be present and they can be treated. The most important is the diet. If the deciduous teeth are retained and they do not exfoliate at the proper time, then your permanent teeth will not have enough space. They will be erupting from abnormal directions. So we need them to erupt at the proper position. That's why we shall see what diet this child is eating. If the child is eating a very soft diet, and the child is having more sticky diet, so it will not exert any pressure over the teeth to exfoliate. That's why we shall see the diet patient is using. Number two, due to prolonged retained deciduous teeth, you see here the permanent teeth are more lingually placed. They erupted, but they erupted in the wrong direction. Similarly here, due to retained deciduous teeth, this canine has erupted into the wrong direction, more buccally. So these retained deciduous teeth not only cause abnormal positioning of the teeth, but they rather cause a midline shift. They can lead to midline shift. You see here, whole the midline is shifted. So what do we need at this stage? That when we see the exfoliation time of the deciduous teeth, if it is over, then we should extract them. It doesn't mean that we extract the teeth before time. We should wait for the particular time for the teeth. If we see that they are retained now after their shedding time, then we need to extract them. The presence of supernumeraries can also guide the permanent teeth to erupt into the abnormal direction. You see, these supernumeraries can be, this is the supernumerary tooth, means an additional tooth is present. So this additional tooth is present, so the teeth, the normal teeth, the permanent teeth do not get enough space, so they try to erupt into the abnormal direction. So such teeth need to be extracted. The presence of fibrous or a bony covering over the teeth that does not allow the teeth to erupt should be removed. The overlying, if it is an overlying bone or if it is a overlying soft tissue. But first you need to assess that clinically and radiographically, then we need to remove. So these barriers or extraction of teeth is to be done when we know that the patient has the dentition, the deciduous dentition has crossed the exfoliation time, then we shall extract the deciduous dentition. And when we see in the radiograph, the permanent tooth has erupted for around, you see, more than half of its eruption process is complete, and now it is near the bone. Only the barrier which is present is not permitting it to erupt. Then we try to remove them. Another problem during the interceptive orthodontics which need to be resolved, that is called as crowding. Crowding word is self-explanatory, that when there is little space and several people are standing, that is called crowding. The similar cases with the dentition, when there is no enough space into the arch and the teeth do not get enough room to accommodate into the arch, so they lead to crowding. And these crowdings cause several problems of dentition and the gums and the periodontal tissues. First of all, we should understand where the crowding is occurring, why the crowding is occurring, in which region is the crowding present, and how do we relieve the crowding, and how much the crowding is present in millimeters. So crowding in the dentition, during the mixed dentition, is severe if it is not treated early. In the mixed dentition, the severity of the crowding, if not treated, then the permanent dentition will not get enough room to be accommodated, and they will cause worst malocclusion. There are two ways that the dentition, the deciduous dentition, is replaced by the permanent dentition, and how do they accommodate. The permanent dentition, when erupts into the oral cavity after the exfoliation of the deciduous dentition, has, when we see normally the mesiodistal width of the incisors, if you see about the permanent teeth, it quite wider when we see the dentition, the deciduous dentition. So it's natural when they need to erupt, they need to have enough room. So there are different physiological changes present into the oral cavity when there is a transition between the transition stages are present when the deciduous dentition is replaced by the permanent dentition. So what are these transition stages when the deciduous dentition is changed to a permanent dentition, replaced by the permanent dentition? How they accommodate into the arch? For the incisors, if we talk about that, I told you the mesiodistal width of the incisors, the permanent incisors, is quite wider than the mesiodistal width of the lower incisors. So when they accommodate into the arch, there is, a nature has created the deciduous dentition in a way that the spaces are normally present between the deciduous dentition. These spaces which are normally present between the deciduous dentition, they are called as physiological spaces. These physiological spaces help these wider teeth to accommodate into the arch. Number one. Number two, the positioning. If we see the deciduous incisors and we see the permanent incisors, their inclination is different. These are the permanent incisors. And when I draw the deciduous incisors are normally present upright into the arch. They are normally upright like this. So when the permanent teeth erupt, they erupt in this direction. Their inclination is quite outward, more labially. When they erupt labially, this way they also accommodate into the arch. So I'll be talking about what's it, incisor liability. The incisor liability is nothing but it is actually when the mesiodistal dimension of the deciduous dentition is lesser than the permanent dentition. The spacing present between these dentition, the deciduous dentition, help them to accommodate into the arch. So that is called as incisor liability. This is for the anterior teeth. Similarly, when we go for the posterior teeth, the canines and premolar, when they erupt into the oral cavity, if we compare with the deciduous dentition, the canine is replaced by the canine, but the molars are replaced with the premolar, and both the molars are replaced with the premolars. So what happens if we see the major distal width of the deciduous molar is wider, but the premolar is not that wider, which is going to occupy this space. Both the premolars, when they occupy this space, after exfoliation of the deciduous molar, you find that there is a space left behind. You see, they are wider comparatively than the permanent premolars. So the space which is left behind here, that is called as leeway space of Nance. This space helps these molars to the permanent molars to accommodate into the arch. So this way, the nature has created spaces that helps in the permanent dentition to have a proper positioning into the arch in order to avoid crowding. This leeway space of Nance is different in the upper arch and it is different into the lower arch. It is less in the upper arch and it is more into the lower arch, number one. This 0.9 mm of the space is present in one quadrant. Similarly, the same space is present into the other quadrant. So together we say that this space is around 1.8 in the upper arch on both sides, millimeters in millimeters. Similarly, when we see for the lower arch in the mandible, it is present as 1.7 on one side of the arch and it is present 1.7 on the other side of the arch. So together this is 3.4 mm in the lower arch. So these spaces actually help the permanent dentition to accommodate into the arch without crowding. Another way is increase in the intercanine width. I've discussed these things, so I'm not going to waste my time on it again. I am telling you another way of how the dentition accommodate, the permanent dentition accommodate, it is again increase into the intercanine width. As the child grows, this intercanine width increases, that also helps the permanent dentition to accommodate into the arch. We talked about interdental spacing. These are called as natural physiological spaces present into the arch, upper and lower arch of the deciduous dentition, and they help to accommodate the permanent teeth. This is actually, these arrows are showing that here and here, the canines are present. There is increase into the intercanine width that also helps to accommodate the teeth. These spaces are called as primate spaces or physiological spaces, and they are around 2 to 3 millimeter. These spaces are around 2 to 3 millimeter present into the dentition. This is the intercanine width, as I told you. Now, please remember, intercanine width is greater in maxilla when we compare to the mandible. And this is around 3 to 4 mm of the space. But if there is premature loss of the deciduous tooth, there is early shedding of the deciduous tooth, then this intercanine width is lost and patient may have malocclusion. Patient may have lot of dental issues. I have explained you that the labial positioning of the permanent dentition is different than the deciduous dentition. You see, these are the permanent teeth. Their labial positioning, you see they are following some angle. But if there would have been a deciduous tooth, then the deciduous tooth would have been like this. So this labial positioning also helps in relieving the crowding. This also creates a space of 1 to 2 millimeter. So how do you know whether the crowding is present or not? How much crowding is present? How much space to be required to treat the crowding? And how will we gain the space to treat the crowding? For example, if you have observed that the patient is having 4 millimeter of the crowding into the arch, what will you do? There are several ways to treat the crowding, but before treating crowding, we need to have space. The crowded arch is there. We need to create the room for the teeth. How will we create the room? There are different ways to create the room. We can slice the teeth. This is called a disking, slicing, or stripping of the teeth. We can go for expansion of the arch. We can go for extraction of the teeth. But the treatment is not same for all the cases. It varies. How? It varies because first of all, we need to know how much space do we really need to treat the crowding. If I require 4 mm of this space to treat the crowding, it doesn't mean that I try to extract the tooth. No, we cannot extract the tooth. There are different treatment options for crowding to treat the crowding into the permanent dentition. We'll be discussing it later in another tutorial, but here we are talking about the crowding into the mixed dentition. So the treatment options are different. Please make this clear. The treatment is different for the crowding when it is for the permanent dentition after the eruption of all the teeth. So one way of the crowding to be treated, if we know that the space required is not more than 4 millimeter, then we slightly do stripping. We do slight stripping of these teeth to create 4 mm of the space, and we try to relieve the crowding. Stripping can be done on all the incisors as well as till the distal surface of canine, but in some cases we can do the disking of the mesial surface of molars also. It depends upon in which segment is crowding present. If the crowding is present in the anterior segment, it doesn't mean that you start disking the premolar. If it is into the anterior segment, do the slicing on the anterior segment. If it is crowding is present into the posterior segment, then go for the disking into the posterior segment. It depends. Where do we need to treat? After disking, please keep in mind, when we grind the teeth, we strip the teeth, they are more prone to sensitivity. So after disking, we shall apply fluoride over the teeth. There shall be a fluoride application in order to prevent sensitivity to the teeth. Another way of crowding is to do some extractions. That is called the serial extraction. Please keep in mind, serial extraction is done in only mixed dentition stage. If it is a permanent dentition, we don't call it a serial extraction, we call it extraction. Serial means some series is extracted one by one. So that serial extraction is the one where some of the deciduous and some of the permanent teeth are extracted. But when we talk about the extraction for the permanent dentition, that is only called extraction. That depends that which tooth to extract. It depends upon the type of malocclusion. If it is class 1 malocclusion, we will extract some particular teeth. If it is class 2 malocclusion, we extract the particular teeth. And if it is class 3 malocclusion, we extract some particular teeth. But if it is the mixed dentition and interceptive orthodontics, we extract some of the deciduous and some of the permanent teeth in order to relieve the crowding. Then after the extraction, you cannot leave the patient like that. You need to apply some corrective orthodontic treatment for some time, not for a long duration, for some short duration. And we try to align the teeth, and we try to occupy the spaces which we have created with the extraction. Serial extraction doesn't mean that we extract the teeth and we ask the patient goodbye, go home. No, we need to treat such cases with corrective orthodontic treatment. So we'll be talking about what is serial extraction and what are the ways to do. Serial extraction is nothing but it is a planned sequential removal of the primary as well as permanent teeth in order to relieve the crowding. The sequence is given by some authors in a different way, and it is given by some authors in a different way. I'll be explaining all of them in when we'll be proceeding further. What is the purpose of serial extraction? As I told you, when there is a crowding, what first thing you need to relieve the crowding? When this is the room and this room has only capacity for 10 people to stand. But if there are 18 or 20 people trying to accommodate in this room, do you think this room would be enough for them to accommodate? Instead of standing properly, they will be standing over each other. And this standing over each other is called as crowding. So the first rationale of serial extraction is you need to have space into the arch. You need to gain the space into the arch because the arch length is not sufficient to accommodate the tooth material. Before planning serial extraction, first we should know how much space do we need. Then a planned extraction is done. Why is this planned extraction is done? Because we need to have space in the arch for the teeth which have not yet erupted into the oral cavity to accommodate properly. And serial extraction is more physiological way of treating the crowding, because we are extracting some of the teeth which are present into the arch, and we are permitting the future teeth which have not yet erupted into the arch to have a sufficient room to erupt into the oral cavity without crowding. So that is more physiological way of treating. This serial extraction is, as I told you, we are talking about interceptive orthodontics. So it is done during the mixed dentition stage. And it guides the eruption of the teeth which have not yet erupted. It tries to resolve as we know that we have intercepted that if we do not extract some of the teeth before, then the teeth which are going to erupt into the oral cavity will not have sufficient room, and they may cause abnormalities or irregularities into the dentofacial complex. These extractions, these planned extractions, somehow help your future permanent teeth which have not yet erupted. They guide them to erupt properly into the oral cavity, and they guide them a proper pathway of eruption. It also reduces patient's discomfort. Like you are treating patient carefully during his mixed dentition stage, then in future patient may not have the crowding which you anticipated that would happen. It is also cost effective. As I told you, it is more physiological because we extract the teeth, we apply some of the corrective orthodontic treatment to align the dentition, and we provide room for the future teeth to erupt into the oral cavity. So this is called as it is more cost effective. Patient do not have to bear a lot of expenses on it, and it reduces the discomfort on the patient again because the treatment is not that prolonged as it is in corrective orthodontics. So what are the indication of serial extraction? Please keep in mind that serial extraction can be done in class 1 malocclusion when there is a normal skeletal pattern. When the skeletal pattern is class 1 skeletal pattern and the musculature is normal and there is a class 1 malocclusion, then you need to go for serial extraction. And when you know that the space required per quadrant is more than 5 mm or 5 mm. So indication is class 1 malocclusion, the skeletal pattern shall be class 1, there is no muscular hyperactivity, and the space required in each quadrant is 5 or more. Means together the space required is around 10 millimeters. When there is arch length deficiency, we know that the arch length is less like this and tooth material is more, so we need to go for serial extraction. There are some pathological conditions and there are some non-pathological conditions which leads to deficiency of arch length. How this arch length gets reduced, you see here, if I say this is the deciduous molar, these are two deciduous molars, okay, and what happens, here are proximal caries to this tooth. You know what happens due to these proximal caries, this tooth structure is lost. What will happen when the tooth structure is lost? This tooth will have, for sure, this tooth structure is lost, so it means there is a gap. So this tooth will try to tilt into this gap. When this tooth tries to tilt into this gap, the arch which was present over here will try to shrink. So this way, these mesial migrations of the teeth due to proximal caries causes deficiency of arch length. Or there is a premature loss of a tooth and we did not give space maintain and we did not maintain the space due to the premature loss, there can be again the arch length deficiency. And if we give improper restorations, these improper restorations also cause mesial drifting of the teeth and loss of arch length. And the teeth which are ankylosed, which have not yet erupted into the oral cavity, they may also lead to deficiency of arch length. The non-pathological way is when there is a mandibular shift. You see here, the mandible has shifted due to early loss of any deciduous tooth or due to early loss of deciduous canine. The mandible has shifted to the side where the loss has occurred, or there is abnormal canine resorption, or the canine is blocked out. You see, this canine is present over here. Do you think if the canine is erupted over here, this arch won't shrink? You don't think this is the tooth present. You just feel this tooth is not over here and this is the empty space. If there is nothing on this, there is no tooth on this empty space, the arch will start to shrink from here. And this way, the arch length will reduce and the tooth material become more. That is not more with magic. It is normally there. But since our arch is not sufficient to accommodate that, so we are saying the tooth material is more, but the arch length, the room is not sufficient. What are the contraindications where you don't do serial extraction? Class 2, class 3 malocclusions. And the skeletal class 2, class 3 abnormalities. Here, it is contraindicated to do serial extractions. When there is mild to moderate crowding, we do not do serial extractions. When per quadrant, the discrepancy is less than 5 millimeters, we do not do serial extraction. You just reverse it with the indication. Indication said you shall have more than or up to 5 mm of space required per quadrant. When the dentition is already spaced, you see this dentition is already spaced. Does it make sense to do the serial extraction? No. Due to oligodontia, some of the teeth are naturally missing. We cannot do serial extraction because we do have space present. When the cases where there is an open bite, I'll explain it why don't we do serial extraction into these cases. And when there is a midline diastema, diastema means spacing between the two central incisors. It is present, we do not do serial extractions. So you shall remember the indications and contraindications of serial extraction. Before planning any treatment, before planning any extraction, you shall have to go with some diagnostic steps. Blindly looking in the patient's mouth, I cannot say that the space required is 3 millimeter or 10 millimeter or 8 millimeter. No, we shall follow some diagnostic steps. The first diagnostic step is always your clinical examination. You need to see whether there's malocclusion present or not. Once you found there is a malocclusion present, then you need to investigate. What are the ways to investigate? That how much space do we need? First of all, you take the impression of the patient and you make a study model. On this study model, we see what is the shape of the arch, how much tooth material is present, how much deficiency is present. That will be carried out by some analysis. Those are called as model analysis we need to do. And some standard model analysis are there which we need to follow. Once we do the model analysis, then we come to the conclusion that how much space do we require. These two examinations are not sufficient. The clinical examination study model to carry on the extraction, you need to have some other examinations like radiographic examination. You need to have some radiographs to find out that what is the stage of the dentition present which need to be extracted, whether there is a crowding, whether there is a pathology. We cannot blindly do extractions. We need to extract the teeth after proper planning, following the diagnostic acts. And after the radiographs, you need to have photographs of the patient to keep record for the patient. This record will be followed between the treatment and they can be followed after the treatment to see the changes which our treatment has brought. What is the purpose of having radiographs? The purpose of having radiographs, we need to see whether there is any supernumerary tooth present into the arch or not. First of all, it gives us a clue. This OPG gives us a clue about the age of a patient. What is the age of the patient? Number two, it also tells us about, you see, what is the stage in which a permanent tooth is present, the no-Laz stages. In what no-Laz stage a tooth is present into the oral cavity, which needs to erupt into the oral cavity. For example, here, this tooth is yet present over here. You just see it's no-Laz stage 4. And this is the deciduous tooth present. It guided me that this deciduous tooth should not be extracted at the moment because this tooth need to be at least in no-Laz stage 7 or 8. So these diagnostic tools gives us clues whether or not to extract the tooth, at what time to extract the tooth, whether there are barriers present, whether there are pathologies present. And they not only the dental, it gives us the, the proximity of the dentition with the vital structures. And also it guides us about the facial profile, the soft tissue profile of the patient. What is the profile like in cephalometric analysis? We see the facial pattern of the patient, the soft tissue blanket of the patient, the profile of the patient. They also help us to, keep these records for the mid-treatment and post-treatment relationship to compare. So after these diagnostic ads, we will plan the serial extraction. Different authors have given different methods of serial extraction. These 4 methods I'm explaining over here. One is the Twitch method, one is the Dewell's method, Nance method, and Grew's method. Every method is different from each other. The extractions are same, but the pattern is different. The sequence is different. So we are going to talk about Twitch method of extraction. I have made this mnemonic for the ease. I hope it will help you out. TWID, do count 4 to 8. Means according to TWID, do count 4 to 8. At the age of 8, you do the serial extraction. Why do we do at the age of 8? Why not before or why not after? Because we know after the eruption of anterior teeth, the posterior teeth which erupt into the oral cavity begins to erupt from the age of 8, like if we are talking about the premolars and canine. So at the age of 8, when you plan the serial extraction, according to TWID, you first extract the D, then extract the C, and then extract the 4. 4 means premolar. I told you in serial extraction, we extract some of the deciduous as well as some of the permanent teeth. So Mr. Tweed says that at the age of 8, you first extract this tooth. You see, if I extract this tooth, this is D. After this tooth, this. Now, as soon as you extract this tooth, don't you think this tooth will have ease of eruption into the oral cavity? Okay. After this tooth, he says, now you see the D is extracted over here and the premolar has erupted at its place. In this picture, let me clear it again. You see D is extracted. Now this premolar, which was over here, it has erupted into the oral cavity. The purpose of removing this D from here is to allow the premolar to erupt into the oral cavity, because I cannot drill the hole in the bone and extract the premolar. I need this premolar to erupt into the oral cavity so that I can extract it for my treatment purpose. So that's why I've created D. After the extraction of D, he says extract this C. As soon as you extract this C, this canine will be guided to erupt into the oral cavity, the permanent canine. After C, you extract this 4 which has erupted into the oral cavity after the extraction of D. So this way, we have extracted 3 teeth, the D, the C, and the 4. DC4 extraction helped us to relieve the crowding present into this anterior region. We have, this canine will be erupted easily into the oral cavity. These teeth which had a crowding present, they were treated with the fixed orthodontics appliance for a short time, and we tried to have the treatment in earlier stages of development in order to have more physiological results. And this way, the patient will have less discomfort and the results will be more cost effective. So after TWID analysis, we have DeWell's analysis or DeWell's method of tooth extraction. See, remember, TWID says do count 4 to 8. DC4 is the extraction pattern at the age of 8. Excuse me. For the DeWell's method, the pattern is different. Instead of DC4, we have the extraction pattern as CD4. Again, mnemonic for DeWell climbed door first at the age of 8.5. According to Mr. DeWell, the extraction should begin at the age of 8.5. But the pattern has to be C, D, and 4, not the DC4, as we studied earlier. According to him, you extract the D's first, the C's first, means canine, and allow the permanent canine to erupt into the oral cavity with ease. You see here in this picture, the canine has is erupting or nearly erupting, and the extraction of D before time has tried or has helped these lateral incisors which were crowding to move distally to relieve the crowding in this segment. The central incisors will have room to accommodate themselves easily by means of corrective orthodontic treatment. And after the C, we will extract the D. The extraction of D will allow the eruption of this 4, the premolar. Then we quickly extract this 4 as soon as it erupts into the oral cavity. That will guide this canine to erupt into this space. And this way, we try to relieve the crowding into the anterior segment. But make one thing clear, that you shall do radiographic analysis of first premolar, that when the half of the root of the first premolar is complete, then you try to extract. Because when half of the root of the first premolar will be complete, then it will be erupting into the oral cavity. But if it is not, half of the root is not formed, then it will not erupt into the oral cavity. So you try to see radiographically, you assess properly, and then we plan the extractions. But at the same time, we have to carry on the alignment. The space which we have created, we cannot blindly leave the extraction spaces. We need to do corrective orthodontic treatment for the proper alignment of the segment, anterior segment for which we have created the space. This is the modified Dewell method. He says that you need to understand what is in the radiograph, that what is the level of premolar into the arch, and we try to enucleate the premolar. Even then, if it is not yet erupted into the oral cavity, you try to enucleate and you remove this tooth, the first premolar. Okay, and the extraction is done at the same time when you do the extraction of deciduous first molar. Another Nance method of extraction. The Nance method of extraction says that the extraction pattern is DC4. So according to Nance, the extraction pattern is DC4. Says that the extraction should be done at the age of 8 years. It has to be done at the age of 8 years. But the extraction pattern, when we saw in the earlier two authors says that extract the deciduous teeth before, and in the end, you extract the permanent teeth. But here you see, he says extract one of the deciduous tooth, followed by its procedure, the 4, then extract the deciduous canine. So his extraction pattern is extract the D's, means deciduous first molar at the age of 8 years. After we know that the space created by the D, which tooth will erupt? For sure, the succedaneous tooth, which is the first premolar, that is 4, will erupt. So he says after the extraction of D, you extract the first premolar, which has erupted into its place, or which is erupting into its space, and then you extract the deciduous canine. So this is the pattern of extraction for Nance, and then we try to relieve the crowding into the anterior segment, as well as some of the crowding into the posterior region can also be relieved. Because the extraction of the premolar, because see, one of the tooth which we are extracting is the premolar, the first premolar, which is a permanent premolar. And the position of the first premolar in the arch is such that it not only helps us in relieving the crowding into the anterior region, but it helps us relieving the crowding in the posterior region as well. You see here, this tooth is the choice of extraction even when we do the corrective orthodontics. Right now we are talking about the serial extraction. In the interceptive orthodontics mixed dentition period. But if we see the corrective orthodontic, the first choice of extraction for us is this first premolar, because the position of the first premolar is ideal in the arch, that it helps relieving the crowding in the anterior region, and also it helps us to relieve the crowding into the posterior region. Number 1. See, I'm giving you additional information over here, although not needed, but we'll be talking about the treatment plannings in different conditions. So I just want to give you an idea why first premolar, why not second premolar we extracted over here? Why didn't we extract E's over here rather than extracting D's? So the purpose of extracting these premolars and D's, because they are present into the arch where in the position where the crowding in both the segments, the anterior and posterior segment, can be best treated. Number one. Number two, the anatomy, this anatomy of the second premolar, this is the second premolar, and the anatomy of the permanent canine is such that they make a good contact with each other. When we treat the arch with the corrective orthodontic treatment, all these teeth, when they get aligned, what happens? We extracted the premolar from here. You remember? We extracted this premolar from here. We created a space for these anterior segment and posterior segment to be well aligned. What happens at the end of the treatment? These teeth, this canine and this premolar, will meet each other. They will meet each other to close the space and to relieve the crowding. The contact between the canine and the premolar is such that it gives more physiological relationship. This is the reason that we extract premolars, first premolars. Another method is called as Greuze method. Since English is not my native language, so my pronunciation will be different for sure, and the pronunciation which is actually for this name may be different. So please forget this. And so I'll be discussing about Greuze method. In Greuze method, he says the extraction should be done on the basis of the clinical examination. These sequential extractions will be done once you do clinical examination. He says do the extraction in class 1 malocclusion when these different conditions are present. He says do the extraction in class when the skeletal and dental pattern is class 1 and such conditions are present with the class 1, then you do the extraction. What are those conditions? He says when the skeletal and dental pattern is class 1 and there is early loss of deciduous canine. He says when there is a mandibular arch is crowded into the anterior region, but the skeletal and dental relationship is class 1. He says do the extraction when there is class 1 skeletal dental pattern, but the deficiency is around 6 to 10 millimeters. According to him, you can do extractions in dental class 2, although earlier we said this is the contraindication for the serial extraction to do for class 2 and class 3. But he says when there is a dental class 2 with normal overjet. I hope you know what is overjet. Overjet is actually the overlapping between the central and lateral central incisors and lateral incisors upper and lower. This is called as overjet. This is called overjet, the vertical overlap. The horizontal overlap, sorry, not vertical, but the horizontal overlap. This horizontal overlap is called as overjet. So he says that do the extraction also in class 2, dental class 2, I'm not talking about skeletal class 2, but when the overjet is normal, you see here, the molar relationship he says is class 2, means the mesiobuccal cusp of upper first molar should lie in the central groove of the lower first molar normally. But here the cusp is ahead. So this is class 2 molar relationship. So class 2 molar with normal overjet, you can do the extraction when there is a slight dental or skeletal class 2 pattern with minimal overjet. So means both the skeletal and dental pattern of class 2 with minimal overjet, we can go for serial extraction. This is the scenario according to him that when there is early loss of deciduous teeth. I told you when there is early shedding of the deciduous teeth, what happened? The midline shifts to the affected side of the extraction. If early loss is over here, the midline will shift towards the, for example, it's the right side. So midline will shift to the right side. If early loss is present over here, then the midline will shift to the left side. Number one, when there is early loss, the midline will shift. So how will you treat this case? If you see the midline is shifted and arch length discrepancy is 5 to 10 millimeters, then we can plan the sequential extraction. The extraction sequence, according to him, is that you extract the deciduous first molar, followed by the extraction of the first premolar when half of its root is complete. Please keep in mind that we do the extraction of the deciduous first molar, followed by the extraction of the premolar when half of roots of the deciduous molar are developed. But if the roots are not developed up to half, then please delay the extraction of deciduous first molar. You cannot imagine this. You have to understand radiographically that is the root of the premolar half developed, then you extract the deciduous molar. Soon after that, you extract the premolar. But when on radiograph you find that roots of the premolar are not half developed, they're lesser than that, then please wait for the roots to complete to half of its development, then extract the deciduous molar, followed by extraction of the premolar. The treatment shall be delayed. As soon as the premolar erupts into the oral cavity, you extract it. So in this case, if the asymmetry is present on both sides, if unilateral asymmetry is present, and if the bilateral asymmetry is present, in case if the asymmetry is present on both the sides of the jaw, then serial extraction would be difficult to achieve. Please note this thing. Another scenario is when there is class 1 malocclusion and there is a crowding into the mandibular arch, and that crowding is more than 5 mm per quadrant. Means together it's 10 millimeters. So you shall extract the deciduous canine, then you extract the deciduous molars, followed by the extraction of the permanent premolars, keeping in view that half of its roots are completed. If there is another scenario, the third scenario, when there is class 1 malocclusion with the deficiency of 6 to 10 millimeters, then in such case, remove the first premolars as early as possible. You cannot remove the first premolar because it has not yet erupted. Your deciduous tooth is there. So you extract the deciduous molar, wait for the premolar to erupt into the oral cavity, extract the premolar, then extract the deciduous canine. Again, according to him, we can do the extraction in dental class 2 and skeletal class 2 with the condition that the overjet is normal. There is no increased overjet. So in such cases, when there is scenario is when there is no crowding in the lower arch, the crowding is only present into the upper arch. So the proposed extraction sequence is extract C's, extract D's, and extract 4's. Another scenario is when here we had only dental class 2, but here we have dental, or we can have a skeletal class 2 pattern with minimum overjet. Then the extraction sequence is extraction of maxillary deciduous molars and mandibular second deciduous molar. See guys, here we are doing extraction in both the arches, not only in a single arch, the upper arch as well as in the lower arch, because the skeletal pattern is class 2. I'll be discussing in detail in my next tutorials that why are we doing extraction in class 2 in both the arches, why do we do extraction for bimax proclination in both the arches, and why do we do extraction in both the arches for class 3 patterns. So we'll be discussing it later. But you shall understand here that when there is a skeletal class 2 pattern, so he said that you extract the deciduous first molar of the maxillary arch, deciduous second molar of the lower arch, followed by mandibular second premolar extraction. You see, please, second deciduous molar we are extracting in the lower arch. So we are extracting second premolar in the lower arch. We are extracting deciduous first molar in the upper arch. So we are extracting the maxillary first premolar in the upper arch. The extractions are different. Earlier, nowhere we saw that we are extracting the second premolars, but here we are extracting the second premolars to have good class 1 relationship at the end of the treatment. So after this extraction, you go for the corrective intervention and get the results. What are the advantages of serial extraction? We have discussed this before. The results are more physiological. The treatment time is reduced. It is cost effective. It causes less trauma to the patient. It helps, preserving the tissues which are surrounding the dentition, and you achieve more stable results. The disadvantages of serial extraction. The serial extraction approach is not a universal approach in every case. In every case, you cannot say there is a single approach applied or a universal approach applied. No, it varies with the case to case. You need to have a good clinical judgment of the case which you're going to treat with serial extraction. And serial extraction does not give you result in 2 to 3 months, but it takes 2 to 3 years, because some of the teeth we extract, then we wait for some of the teeth to erupt into their place, and then we give the corrective orthodontic treatment. So multiple extractions with corrective orthodontic treatment require 2 to 3 years to complete this process. For sure, when you are doing in mixed dentition state, it means it is a child. So the cooperation of the child is required to complete the treatment. And the places where we do extraction, it is a natural tendency that the patient starts to build the habit of tongue thrusting into the extraction spaces. And the residual space after the extraction, the residual space sometimes be left between the canine and the premolars. And that may cause the ditching. Another thing, that these extraction may lead to deepening of the bite. That's why serial extractions are contraindicated in the cases where there is already deep bite present. And it needs corrective orthodontic, means fixed treatment therapy. Those were the cases where we were doing serial extraction in the dental problems. It means interceptive treatment we were doing in the dental problems. We can do interceptive orthodontics in the skeletal problems at an early stage to prevent the malocclusion to reach to its, the final worst stage. So the malocclusion, the skeletal malocclusions can be treated during the interceptive orthodontics by means of myofunctional appliances. These myofunctional appliances, myo means muscles, they somehow affect the muscle, they redirect the muscles, and by redirecting the muscle forces, it guides the jaws to achieve the normal position. So these myofunctional appliances are also called as functional jaw orthopedic appliances. These appliances can be tooth-borne appliances, they can be tooth-borne active and passive, and they can be tissue-borne appliances. So to carry out interceptive orthodontic treatment with the skeletal malocclusion, we go for therapy with some appliances. These are called as myofunctional appliances. So what are the conditions where we do the interceptive orthodontics in skeletal problems? When there is a skeletal class 2, when there is a skeletal class 2 pattern or class 2 malocclusion is there. What is class 2 malocclusion? As I told you, it is the condition where your maxilla is ahead. The maxilla is prognathic. There can be several reasons for the maxilla to be prognathic. Number one, either the maxilla has increased growth. The maxilla has increased growth, but the mandible is normal. Condition number two, when the maxilla is normal, but the mandible is decreased in growth. And condition number three is when the maxilla is having increased growth and mandible is having decreased growth. I'm explaining again. Condition one, when the maxilla is having increased growth and the mandible is normal. Condition number two, when the maxilla is normal, but the mandible itself is having reduced growth. Condition number three, when the maxilla is having increased growth and mandible is having decreased growth. So in all the ways, there is a skeletal class 2 pattern. So how do you treat? Because in class 2, we are going to treat the maxilla if there is hyperactivity of the maxilla or increased growth of the maxilla. There is excessive growth of the maxilla, then you treat the patient with a face bow. That is, this appliance is called as a face bow. That is called as face bow. It has some components. We'll be discussing them in the different, in my other upcoming tutorials, inshallah. So we treat the patient with myofunctional appliances because the patient is growing patient. And if it is a maxillary growth, excessive maxillary growth, we treat the patient with a face bow along with the headgear. But if there is a decrease, the case is due to decreased mandibular growth, then the treatment will not be carried out with this appliance. The treatment will be different because your mandible is retrognathic. Maxilla is normal. You do not have to do anything with the maxilla. The problem is here with the mandible. So you need to guide this mandible to go forward and achieve a proper position. So for guiding the mandible, you need to give the patient some myofunctional appliances. There are different myofunctional appliances with the different indications. We'll be discussing them later. There is another condition that is called as class 3 malocclusion. In class 2 malocclusion, you had an excessive growth of the maxilla, but that is opposite in class 3. You have an excessive growth of the mandible. Similarly, the excessive growth of the mandible could be either your maxilla is decreased and the mandibular growth is normal, number one. Condition number two, when the maxilla is normal and the mandibular growth is increased. Number three is when the maxilla is decreased in growth and the mandible is increased in growth. In all the ways you see the mandible is protruded forward. And this gives the patient an appearance of class 3 skeletal pattern. Now the treatment depends upon if you think the class 3 pattern is because of decreased maxillary growth, then you think of giving appliance that is called as myofunctional appliance, and we give a Frankel 3 appliance. The 3 appliance is made for class 3 skeletal pattern. If you think there is reduced growth of the maxilla and increased growth of the mandible, then you need to stop the mandible from growing forward. So you need to give a chin cup. You do not want this mandible to grow forward more. You need to stop it. You apply a cup over a chin. That chin cup will be applied to stop the mandible from growing forward. We will go in a detail of all these appliances and all these malocclusions, inshallah, in the upcoming sessions. See, myofunctional appliances are the appliances which are actually bulky in design. They are not usually accepted by the patients because of their bulky design. They are hard, they're stiff. So the recent techniques are there in which we use CAD/CAM technique. These CAD/CAM technique make the same appliances with the lighter weight. They are made of more flexible material and they are made soft in nature. So they are more acceptable to the patients. So this is how we treat the different conditions in interceptive orthodontics. I'm going to conclude my session that we said what is interceptive orthodontics. I told you that it is the orthodontic treatment which we begin at the developing stage of the malocclusion in order to prevent the further or developed problems of the dentition as well of the skeletal pattern. So we intercepted in between. When do we do interceptive orthodontics? We need to do interceptive orthodontics during the mixed dentition stage, when the child is growing at the perfect time in order to achieve perfect results. How do we do interceptive orthodontics? I told you there are different ways of doing it. First of all, if your molar has occupied the space of your future permanent tooth, the first permanent molar is tilted, you need to upright it, you need to regain the lost space, and that lost space was regained by uprighting the molar by means of a therapy that was called as molar distalization. Number 2, we said we can treat the crossbite during the mixed dentition stage. Number 3, we said that we need to treat the crowding during the mixed dentition stage. There were different methods. We were treating the crowding. One of the methods of treating the crowding was serial extraction. That extraction was done on some of the permanent and some of the deciduous teeth during the mixed dentition stage, followed by corrective orthodontic treatment. As I told you, there are some skeletal patterns they can also be treated during the interceptive orthodontics. These skeletal patterns can be treated by combination therapy of the myofunctional appliances and the orthopedic appliances. I hope I was clear to you, and inshallah this tutorial will be very helpful for you. Thank you for listening to me. Thank you if you understand. Pray for me, and inshallah I'll be sharing my other tutorials sooner. Thank you so much.